Welcome to today's discussion, where we delve into a critical question facing healthcare systems globally. Should mental health services be a standard component of universal healthcare plans, accessible to all citizens? It's a topic with profound implications for individual well-being and societal health. To explore this multifaceted issue, we have two distinguished guests. Dr. Ben Carter, a psychiatrist, who will argue in favor of comprehensive inclusion, and Ms. Olivia Green, a health policy analyst, who will present a more cautious perspective, highlighting potential challenges. We will begin with opening statements from each speaker, followed by a moderated discussion and rebuttals, and conclude with closing remarks. Dr. Carter, would you please begin with your opening statement?
Thank you, Sarah. I believe passionately that mental health is not a luxury, but a fundamental component of overall health, and it must be treated as such within our healthcare systems. For far too long, we've operated under a flawed premise that separates the mind from the body, creating an artificial and damaging divide in how we approach care. The statistics are undeniable. Mental health conditions are incredibly prevalent, affecting millions worldwide, irrespective of age, gender, or socioeconomic status. These conditions, ranging from anxiety and depression to more severe illnesses, have a devastating impact not only on individuals and their families, but also on our economies and societies. From an ethical standpoint, denying or limiting access to mental health care while providing for physical ailments is discriminatory and unjust. Universal health care plans are built on the principle of equity. This principle must extend to mental health. Integrating mental health services into universal health care offers numerous benefits. Early intervention, for instance, can significantly improve prognoses and prevent conditions from escalating, reducing long-term suffering and disability. Furthermore, integration helps to reduce the pervasive stigma associated with seeking mental health support. When these services are part of standard care, it normalizes help-seeking behavior. Many also underestimate the economic argument. Untreated mental illness leads to lost productivity, increased healthcare expenditure on related physical conditions, and higher social welfare costs. Investing in mental health care through universal plans is not merely an expense. It's an investment that can yield substantial long-term savings and contribute to a healthier, more productive populace. It fosters a society that values holistic well-being, recognizing that mental resilience is key to navigating life's challenges. Therefore, the inclusion of comprehensive mental health services within universal health care is not just desirable, it is an essential progression towards a more compassionate and effective health system.
Thank you, Sarah. And thank you, Dr. Carter, for your opening remarks. I share the fundamental goal of improving mental well-being for all citizens. However, while the aspiration to include comprehensive mental health services in universal healthcare is commendable, we must approach this ambition with a strong dose of pragmatism and careful consideration of the practical and financial realities. Integrating mental health services universally presents significant financial challenges. These services, if made accessible to everyone, would require a substantial increase in healthcare budgets, potentially straining already overburdened systems. We need to ask where these additional funds will come from. Will it mean higher taxes or cuts to other essential services? These are not easy questions. Beyond the direct financial burden, there's the critical issue of resource allocation. We currently face shortages of mental health professionals, psychiatrists, psychologists, therapists, and specialized nurses in many regions. Simply mandating universal coverage without a concurrent strategy to expand the workforce and infrastructure could lead to long waiting lists, compromised quality of care, and burnout among existing professionals. Another concern is the risk of over-medicalization. Not every emotional distress or life challenge requires clinical intervention. There's a danger that universal access could lead to the medicalization of normal human experiences, pathologizing everyday stress and grief, which might be better addressed through community support or other non-clinical avenues. Defining the scope of covered services is also a complex task. Which conditions and treatments should be included? What are the thresholds for diagnosis and access? Without clear, evidence-based guidelines, there's a risk of inequitable provision or an unsustainable expansion of services that are not clinically essential or cost-effective. While I agree that mental and physical health are linked, the models of care and resource needs can be quite different. A blanket integration without careful planning might dilute the quality of both mental and physical healthcare services. Therefore, I advocate for a more cautious, evidence-driven approach, perhaps focusing on targeted investments and phased implementations, rather than an immediate, all-encompassing universal mandate.
Thank you both for your comprehensive opening statements. Dr. Carter, Ms. Green has raised significant concerns about the costs and resources required for such an integration. How would you respond to the argument that universal inclusion of mental health services might be financially unsustainable and could overwhelm existing healthcare infrastructure?
That's a valid concern, Sarah, and one we must address thoughtfully. However, framing this purely as a cost is, I believe, a short-sighted perspective. Firstly, as I mentioned, untreated mental health issues already incur massive indirect costs through lost productivity, increased use of emergency services for crises, higher rates of chronic physical illness, and social welfare burdens. Investing in accessible mental health care is preventative. Early intervention for conditions like depression or anxiety can prevent them from becoming chronic and more costly to treat later on. Think of it like investing in preventative physical care. It saves money in the long run. The economic benefits of a mentally healthier population with increased workforce participation and reduced absenteeism are substantial. Regarding resource allocation, a phased implementation is indeed a practical approach. We can start by integrating services for common mental disorders at the primary care level, alongside investments in training more professionals and exploring innovative service delivery models, like telehealth, to improve reach and efficiency. It's not about flipping a switch overnight, but about a committed strategic shift towards parity.
Ms. Green, Dr. Carter emphasizes the long-term savings and economic benefits, suggesting the costs of asterisks not tasked integrating are even higher. While you've acknowledged these indirect costs, how do you reconcile this with the immediate budget viability concerns you raised? Are targeted programs a sufficient answer?
I certainly acknowledge the significant indirect costs associated with untreated mental illness. That is not in dispute. The challenge lies in how we manage the direct, upfront investment required for universal integration within the constraints of public finances. While long-term savings are a compelling argument, governments operate on annual budgets and face immediate fiscal pressures. A promise of savings a decade down the line doesn't alleviate the need to fund services today. This is where targeted programs can be more pragmatic, at least initially. They allow us to focus resources on the most vulnerable populations, or the most prevalent and debilitating conditions, where the impact can be maximized with available funds. For instance, enhancing mental health support for young people, or for individuals with severe and persistent mental illnesses, could be prioritized. This allows for a more controlled and measurable expansion of services. Before committing to a full universal model, we need robust, country-specific economic modeling and evidence from pilot programs to ensure its sustainability and effectiveness, rather than risking a system that is underfunded and overstretched from the outset.
If I may, Sarah, while targeted programs sound like a reasonable compromise, they inherently risk creating a two-tiered system of mental health care. This approach often leaves behind individuals who don't fit neatly into specific categories but are nonetheless suffering and require support. It can exacerbate existing health inequalities. Universalism ensures that everyone, regardless of their specific diagnosis or demographic, has a baseline right to access care. It fosters a more equitable society.
And while equity is a noble goal, Dr. Carter, fiscal responsibility is a non-negotiable duty for policymakers. An under-resourced universal system that fails to deliver quality care to anyone is hardly equitable. We must build sustainable systems that can genuinely meet needs, rather than making promises we cannot keep. Careful, strategic planning is paramount to achieving true, effective access for all in the long run.
Let's shift the focus slightly. Dr. Carter, beyond the direct health impacts, you've touched upon broader societal benefits. Could you elaborate on these? What wider positive changes could integrated mental health care bring to communities and society as a whole?
Certainly, Sarah. The societal benefits are vast and interconnected. When mental health is prioritized, we see positive ripple effects across many areas. For example, improved access to mental health care can contribute to reduced rates of homelessness, as many individuals experiencing homelessness suffer from untreated mental illnesses. Similarly, it can play a role in reducing crime rates, particularly for offenses linked to substance abuse, which often co-occurs with mental health conditions. In educational settings, children and adolescents with access to mental health support are more likely to perform better academically and have fewer behavioral problems. This leads to a more educated and skilled future workforce. Within families, addressing mental health issues can strengthen relationships, reduce domestic stress, and improve overall family well-being. Parents who are mentally healthy are better equipped to support their children's development. Ultimately, a society that invests in the mental health of its citizens is a more resilient, productive, and cohesive society. It fosters greater social inclusion and reduces the burden on other social services.
Ms. Green, Dr. Carter paints a picture of significant societal improvement. However, you've raised concerns about the risk of over-reliance on the medical system. Could universal inclusion inadvertently medicalize normal life struggles or divert resources from crucial community-based and preventative supports that fall outside a purely clinical model?
That is precisely one of my key concerns, Sarah. While the societal benefits Dr. Carter outlines are desirable, achieving them requires a multifaceted approach, not solely an expansion of clinical services. There's a real risk that if mental health support becomes primarily situated within universal health care, we might neglect or underfund vital community-based initiatives, peer support groups, school counseling programs, and workplace well-being strategies. These non-clinical supports are often more appropriate, accessible, and less stigmatizing for individuals experiencing mild to moderate distress, or navigating common life challenges like grief, stress, or relationship issues. Medicalizing such experiences by channeling everyone through the formal healthcare system could create unnecessary dependency, pathologize normal emotional responses, and overwhelm clinical resources meant for those with more severe conditions. A truly effective mental health strategy must integrate clinical services with robust social and community support systems, focusing on prevention and early intervention in diverse settings, not just doctors' offices.
I agree that a multifaceted approach is essential, Ms. Green. However, universal access through healthcare doesn't preclude or diminish community support. It can actually strengthen it. Integrated primary care, for example, can act as a crucial gateway, assessing needs and directing individuals to the most appropriate level of care, whether that's specialist treatment, counseling, or indeed, community resources and peer support. It's about creating coherent pathways, not just medicalizing everything.
Those coherent pathways are indeed critical, Dr. Carter, but their design and resourcing are paramount. If the system isn't meticulously planned to manage demand and ensure appropriate referrals, the medical services risk being swamped. This could lead to a dilution of care for those with acute needs. The success of such integration hinges on very careful system design and adequate funding across all levels of support, not just the clinical end.
In closing, I want to reiterate a core conviction. Mental health is a fundamental human right, inextricably linked to physical health and overall well-being. The arguments for integrating comprehensive mental health services into universal healthcare plans are compelling on multiple fronts. For individuals, it means access to timely, affordable care, reducing suffering, and improving quality of life. For public health, it means addressing a leading cause of disability worldwide, promoting early intervention and reducing the pervasive stigma that prevents so many from seeking help. Economically, the cost of inaction, of leaving mental illness untreated, far outweighs the investment required for integration. We see this in lost productivity, strained social services, and increased physical health care expenditures. Viewing mental health care funding as an expense is a mischaracterization. It is an investment in our human capital, in the resilience of our communities, and in the productivity of our economies. This is also a matter of societal justice. Access to mental health care should not be determined by one's income, social status, or geographic location. Universal coverage is the most equitable path forward. The challenges of implementation, while real, are not insurmountable. They require political will, strategic planning, and a commitment to innovation in service delivery. It is time for a paradigm shift. We must move beyond the outdated separation of mind and body in our healthcare policies and practices. Let us build healthcare systems that truly care for the whole person, fostering both mental and physical wellness for all.
I too wish to close by emphasizing that our ultimate goal is shared, to ensure that individuals struggling with mental health challenges receive the support and care they need. The debate is not about the importance of mental health, but about the most responsible and effective way to enhance services on a universal scale. Throughout this discussion, I have highlighted my primary concerns regarding the immediate and full-scale integration of mental health services into universal healthcare plans. These revolve around affordability, the existing capacity of our healthcare systems, and the potential for unintended negative consequences if such a massive undertaking is not meticulously planned. The financial implications are substantial, and we cannot ignore the strain this would place on public budgets without clear, sustainable funding models. Furthermore, the current shortage of mental health professionals and infrastructure limitations are critical hurdles that must be addressed proactively. I advocate for a cautious, evidence-based, and potentially phased approach. This might involve prioritizing services for specific vulnerable groups, investing in pilot programs to test different integration models, and rigorously evaluating their impact and cost-effectiveness before widespread implementation. Such an approach allows us to learn, adapt, and build a system that is both comprehensive and sustainable in the long term. It allows us to expand access without compromising the quality of care or overwhelming our resources. Robust planning is essential. This includes detailed impact assessments, transparent funding mechanisms, clear definitions of the scope of services to be covered, and comprehensive workforce development strategies. We must ensure we are building a system that truly works for everyone. Let us proceed with ambition, yes, but also with prudence, ensuring that our efforts to improve mental health care are grounded in realism and lead to tangible, lasting benefits for all members of society.
Thank you, Dr. Carter, and thank you, Ms. Green, for a truly insightful and thought-provoking discussion. Your distinct perspectives have clearly illuminated the complexities of this issue. We've heard strong arguments for mental health as a fundamental right, and the potential societal benefits of its full integration into universal healthcare. We've also heard important cautions regarding the practical challenges of funding, resource allocation, and the need for careful, evidence-based implementation strategies. The core tension is evident. The undeniable and growing need for accessible mental health support on one hand, versus the significant complexities of designing and funding a universal system that is both effective and sustainable on the other. There are no easy answers, but today's conversation has provided much food for thought. We encourage our audience to reflect on the points raised today as this important conversation continues in our communities and at policy levels.